Hello everyone. In this video we will discuss megaloblastic anemia. Megaloblastic anemia is a group of disorder characterized by a common theme: impairment of the DNA synthesis, defective nuclear maturation due to deranged DNA synthesis. This results in nuclear to cytoplasmic asynchrony. The nucleus lags behind while the cytoplasm matures and accumulates hemoglobin at a normal pace, and this will result into increased cell size. The outcome of this condition is ineffective hematopoiesis and distinctive morphologic changes in all the proliferating cell lines like erythroid, granulocytic and megakaryocytic. Now we'll see the vitamin B12 absorption pathway. Dietary sources of vitamin B12 is meat, fish, eggs and milk or dairy products. Dietary vitamin B12 binds with vitamin B12 binding proteins. This complex reaches to the stomach. In the stomach, this B12 binding protein gets degraded by the pepsin, and B12 is free to bind with heptocorrin. Heptocorrin secretes by the salivary gland. This heptocorrin vitamin B12 complex then reaches to the proximal duodenum. In proximal duodenum, pancreatic proteases cleave heptocorrin and B12 is free again. This B12 now bind with the intrinsic factor which is secreted by the parietal cell of the stomach. Now this B12 and intrinsic factor complex travel to the terminal ileum. Here this complex bind with tubulin receptor on the enterocyte of terminal ileum. This complex is engulfed by the process of endocytosis, and inside the enterocyte intrinsic factor degraded and vitamin B12 is transported to the plasma with the help of transcobalamin 2. So this is the pathway of vitamin B12 absorption. Vitamin B12 are also known as cobalamin, act as a cofactor into very important biochemical reactions. The one is in which homocysteine is converted into the methionine, and in this process there is a methyl group generated, which further utilized by the deoxyuridine monophosphate to get converted into deoxythymidine monophosphate, and this is very essential in the DNA synthesis. So vitamin B12 plays an important role in DNA synthesis. Adenosylcobalamin is also a vitamin B12 cofactor. This play an important role in conversion of methyl malonyl coenzyme A into succinyl coenzyme A. Succinyl coenzyme A then utilized into the citric acid cycle or TCA cycle. Whenever there is deficiency of vitamin B12, this will result into the accumulation of methyl malonic coenzyme A or MMA and homocysteine. MMA and homocysteine then gets accumulated in vitamin B12 deficiency, and they cause the myelin damage, and this myelin damage is responsible for the neurological symptoms in vitamin B12 deficiency. What are the causes of megaloblastic anemia? So B12 deficiency and folate deficiency can result into the development of megaloblastic anemia, and there are several reasons of vitamin B12 deficiency, like in deficiency of intrinsic factor, which can be seen in pernicious anemia, post gastrectomy or congenital intrinsic factor deficiency, distal ileum malabsorption, which is seen in Crohn's disease, ileal resection and some malabsorption syndrome like celiac disease and Whipple's disease. In bacterial overgrowth, there is competition for the B12 absorption and infestation with the tapeworm. They also decreases vitamin B12 absorption. And if the diet is insufficient in vitamin B12, like strict vegan or poor diet, which is seen in elderly due to poor dentition. Folate deficiency can be due to the dietary insufficiency or increased utilization, which is seen in pregnancy and lactation, malabsorption syndrome, and some condition like hypothyroidism. This is not hyperthyroidism, hypothyroidism, malignancies, chronic hemolysis, and exfoliative dermatitis. Some drugs like antifolates, anticonvulsant, and sulfasalazine also impair the DNA synthesis and will result into megaloblastic anemia. This we have already discussed. B12 is found in animal products like meat, eggs, and dairy products. Humans have several years worth of B12 stored in liver. The absorption pathway we have already discussed. Like here are the key events of B12 absorption. Like in stomach, pepsin frees B12 from the food protein, and B12 binds to the heptocorrin. In duodenum, pancreatic proteases release B12 from the heptocorrin, and B12 bind to the intrinsic factor, which is secreted by the parietal cells of stomach. In the ileum or terminal ileum, intrinsic factor and B12 complex bind to the tubulin receptor and is absorbed. In plasma, B12 associated with the transcobalamin for delivery to the liver and the tissues. The pathophysiology of vitamin B12 deficiency anemia. Causes of vitamin B12, as we have already discussed, can be due to malabsorption, pernicious anemia, which is seen in which result into the intrinsic factor deficiency, dietary deficiencies. They all will result into B12 deficiency. Due to vitamin B12 deficiency, there is impaired DNA synthesis, and this will result into ineffective hematopoiesis, nuclear to cytoplasmic asynchrony, in which nuclear maturation lags behind the cytoplasmic maturation and ultimately culminate into increased cell size of all erythroid, granulocytic, and megakaryocytic lineage. On peripheral smear, there are macrocytes, megaloblast, and low hemoglobin on CBC. Due to anemia, there is fatigue, weakness, and shortness of breath is there. As we have discussed, vitamin B12 deficiency will result into the increase MMA and homocysteine level, and they causes myelin damage. So there are neurological effects which is seen in B12 deficiency only, not in the folate deficiency. There is a condition known as subacute combined degeneration of the spinal cord is seen in B12 deficiency. Neurological effects manifest as numbness, paresthesia, and ataxia. Morphological features of vitamin B12 deficiency or megaloblastic anemia. Regardless of all the causes of B12 or folate, the peripheral smear and bone marrow shows the classic findings. In peripheral smear, in RBC, there are macrovalocytes, large oval-shaped cells, and there is anisopoikilocytosis, marked variation in size and shape, which is reflect as increased red cell distribution width on the CBC. Reticulocyte count is normally low, reflecting ineffective production Neutrophil shows hypersegmentation, more than 5 nuclear lobes. Bone marrow is hypercellular due to increased hematopoietic precursor. There are promegalocytes, large RBC precursor with fine lace-like nuclear chromatin, and there are giant forms of giant metamyelocytes, belt form, large, and some large and bizarre megakaryocytes are also seen. So on peripheral smear there are macrocytes, RBC size increase, some macroovelocytes. Some of the RBC shows bluish stippling known as basophilic stippling. Normoblast can also seen, immature RBC secreted into the peripheral smear. This is the hypersegmented neutrophil having more than 5 nuclear lobes, 1 2 3 4 5 6. So these are the classical findings of megaloblastic picture. Now we will see the diagnostic approach to megaloblastic anemia. Patient presented with fatigue, weakness, pallor on complete blood count, MCB or mean cell volume is increased more than 100 femtoliter, and there is anemia, decreased hemoglobin. On peripheral smear there are macrocytes, macroovelocyte, hypersegmented neutrophils. After peripheral smear and complete blood count, we order for the reticulocyte count, which is usually low or normal. On serum biochemistry, serum vitamin B12 and folate level, if the serum vitamin B12 level is decreased less than 200 picogram per ml, this suggests vitamin B12 deficiency. If the serum folate level is decreased, this suggests folate deficiency. If the serum biochemistry is in the gray zone or inconclusive, then we measure the other metabolites like methylmalonic acid and homocysteine. If these two are elevated, this suggests the vitamin B12 deficiency. Then we further identify the cause and address the cause for the treatment. If the MMA or homocysteine is normal, then this suggests the folate deficiency. So this is all about the vitamin B12 or folate deficiency anemia, megaloblastic anemia. Thank you.